Thank you, sir, for that kind introduction. I know it's 6:30 in the evening, and we're all feeling a bit jaded. This topic is an unusual topic. It's unique challenges for girls and women with type 1 diabetes. Very different from Professor Manoria's talk, which was all, futuristic and, high tech. But this is very, very low tech in the sense it's all about how we deal with our, clinically with our patients and about lived experiences of patients with diabetes. And we know that type 1 diabetes affects boys and girls. In fact, more boys than girls in terms of number of people getting affected with the type 1 diabetes. But girls have a completely different, very unique experience from childhood all the way up to much later years. And I'll show you, about that in a bit. Because I just want to point out here, besides when we talk about sex and gender, sex is the biological, the male and the female. So the sex chromosome and the sex hormones determine the biological sex. But if you talk about gender, that is determined by the society. So lifestyle and nutritional habits and exercise and stress and so many other things are all actually gendered things rather than biological sex. So when both of these, there is an intersection and it affects, women, girls and women, you can see the consequences that it can have. So if you look at this, I'm calling this a woman's life. So we keep talking about lifestyle a lot. We have to remember life cycle, which is completely unique in women. So when you take childhood, we know that girls are educated less than boys. So the education part, many girls are actually having, in other countries and in our own country, caregiving responsibilities, socio-cultural norms. And you take puberty, and I'll show you some evidence for that. And what do menstrual cycles mean for a girl with type 1 diabetes, and dating and relationships, stigma and fear and body image, anxiety, social life, and then comes very important, which is what happens to marriage and preconception care and pregnancy itself, and then postpartum. And then now people are living longer. Previously, before insulin was invented, we were having young people die people die at a very young age. They were not reaching menopause. But now we have menopause happening to type 1 diabetes women. So what about menstrual cycle related glycemic excursions? And this is and also menarche itself. The epidemiology of menarche and menstrual disturbances in an unselected group of women with type 1 diabetes. And we also have data from India in this. And if you look at age at menarche, if type 1 diabetes happened before the age of 10, usually their menarche happened about a year or a little more than a year later than people who did not have type 1, and also considering girls who had the type 1 diabetes diagnosed after their menarche. So there was a slight delay in that. They're also supposed to have slightly earlier menopause, which means their whole reproductive life could actually be shortened a bit. So this is something to keep in mind. And I want to show you the secular trend. If you see over the years, actually the age at menarche is coming down in general, and it's also coming down considerably for girls with type 1 diabetes, but still there is a slight delay. And in some of the other countries, the delay has not been seen anymore. And another curious thing is, if you look at the menstrual cycle itself, if you look at the early part of the cycle and compare it to the late luteal phase, in early part of the cycle, for example, if the girl is exercising, she can have more hypoglycemia. This is the hormonal changes. And in the latter part in the luteal phase, they can have more cravings and actually can have more hyperglycemia and even have diabetic ketoacidosis. And I want to tell you that there is something unique in girls called catamenial ketoacidosis. This catamenial ketoacidosis was described much younger in 1942 itself. They were all when the girls were admitted with DKA, and they found out that they were all in the first or second day of their menstrual cycle. So this is something, as physicians, we need to keep in mind, that the girls can have catamenial ketoacidosis, and they need to be counseled regarding that. And what about ovarian morphology itself and PCOS in girls with type 1 diabetes? We typically think of PCOS as a problem of type 2 diabetes. Think again, there is an increased PCOS morphology and PCOS condition even in girls with type 1 diabetes. And I just want to show you here many of the hormonal changes mimic polycystic ovary syndrome in girls with type 1 diabetes, and see the prevalence in girls with type 1 diabetes. So this is another feature absolutely to keep in mind. And now we move on to the next phase, which is they've now become older, and let's say they are getting ready for pregnancy. Do you think that girls with established diagnosis of type 1 diabetes get preconception care? Even the ones who have a diagnosis that's already there do not get preconception care. This is a big audit from the UK, which has very, very clearly shown that not only they are not in good glycemic control, other medications that they use, contraception use, and in terms of checking for end organ damage, all these things are not happening. So very important question for practitioners who take care of girls with type 1 diabetes or even type 2 diabetes, since that's happening now to girls and women in reproductive age. When do we start talking to them about preconception care? And here I want to mention women of reproductive age are considered between the ages of 15 to 49. Our own NFHS starts testing girls between 15 and 49. So, which means we need to start talking to them from 15 onwards. They may be getting married right out of high school. They may not even finish high school. They may be getting married while in college or right out of college, whatever, but at a very young age. So we need to start talking to them from the age of 15 onwards. Very, very important. So this Lancet editorial that said campaigning for preconception health, they concluded this: a campaign for preconception health therefore needs to be clever three-pronged approach, taking the different preconception phases and definitions into account. For start, there should be no obesity strategy, no undernutrition strategy, no non-communicable disease strategy, no adolescent health strategy without including preconception health. So adolescent health means we should include preconception strategy. And so what are these three prongs that they are talking about? See, we can think about things like folic acid, which we start typically a month or two before they are getting pregnant. Or it may be an individual who needs certain other things like their HbA1c to be normalized or their blood pressure medicines to be optimized. But it can also be things like correcting obesity or improving nutrition. So all these things will take different lengths of time. That's what they mean by a three-pronged approach. Moving on to pregnancy. This is 8 weeks old, 23-year-old Yamini, 8 weeks pregnant, and works at a large vegetable market, bagging groceries and cleaning the store for the past 6 years, and she's been married for 3 months. Okay. In this particular girl, she has gestational diabetes. I have a similar presentation of a girl who has type 1 diabetes, absolutely in poor control with an A1C of 9.2, but her family says her obligation is to get pregnant immediately. She has no time to get to an A1C of 6 to 6.5 and make all those other changes that we do before pregnancy, which means you know what is going to happen. She could have either a small baby or a big baby, or any of these birth defects that are now, especially the cardiac defects, which we are now seeing much more than the neural tube defects, thanks to folic acid. We're seeing a lot of cardiac defects. So preparing women with type 1 diabetes for pregnancy and taking them through the pregnancy is a very big challenge that we should be prepared for. And now moving on to slightly older, the type 1 diabetes is associated with increased risk of fractures across the lifespan. This is a population-based cohort study using the Health Improvement Network. And just to show you this difference between boys and girls with type 1 diabetes. At all ages, you can see girls are having worse bone health. So when we are taking care of a girl with type 1 diabetes, it's not just the A1C, not just the fasting PP sugar. It is so many things. It is about their menstruation, age at menstruation, their ovarian reserve. It is also about their bone health. And then moving on to mental health. Very big issue, gender differences in type 1 diabetes management and mental health burden. And I want to show you that compared to the men with type 1 diabetes, look at the women with type 1 diabetes. All of them have, this is depression, this is anxiety. At every level, there is more of this. And then also want to show you the body mass index and body image is a very big problem for girls with type 1 diabetes. And when categorized by BMI, you can see significant differences in depression and anxiety in girls compared to body mass index. Do sex differences in pediatric type 1 diabetes care exist? And in this systematic review, you can see all the good things are on the boys' side. And those bars just tell you that they are having a better deal than the girls. So very important to keep that in mind, that there is also that kind of a provider bias also that is happening with type 1 diabetes. I'm going to end with this. It says, let's talk about sex differences in drug therapy in males and females. One of the big problems is type 1 diabetes, girls and women are not included in research, were not included, and kind of continues even now where they're not being included, whether it is animal research or human research, sex differences being reported. All of these things continue to be a big issue. And of course, socio-cultural attitudes towards so many things, attitude, appearances, all of these are happening. And let me conclude with this by saying we really need to work on the barriers and the stigma at every level, whether it is home level, community level, school level, at every level, we need to work on this. And that's my plea to the organization, that we put out our policy statements that will help come up with better policy at a national level and also from an organization level. This is the last slide I leave you with. It's emblematic of everything. When we think of women, we only think of pregnancy. All other figures you can see are men. We don't think of women as having a heart or a brain or a bone or a muscle or even mental health. Very important to keep that in mind. Thank you so much.
Thank